Good morning, I'm Yujin Kwak from Seoul National University Hospital. It's a great honor to have an opportunity to present. Today, I'd like to introduce a case using a new inflow cannulation method for bi-body implantation in patients with restrictive cardiomyopathy. The patient was a 17-year-old female and developed initially general weakness and leg edema 3 years ago. She had abnormal findings on accidental chest X-ray. After being referred to our hospital, she was diagnosed with restrictive cardiomyopathy and followed up with medical treatment. As her symptoms worsened to near functional class 3 to 4 performance status and the demand for inotropics gradually increased, transplantation was listed as Intermax level 2 and the work for transplantation was performed. The chest X-ray showed cardiomegaly, especially the right atrium was enlarged. On preoperative echocardiography, both atriums were enlarged, but the ventricles were relatively small. MRI also showed that both atriums were enlarged and both ventricles were relatively small, and bilateral ventricular function decreased. LVEDP and RVEDP were elevated, and pulmonary hypertension was accompanied on catheterization. Based on the previous clinical results, bypass were planned as bridging therapy before transplantation with the following diagnosis. However, a new inflow cannulation method with a transeptal approach was tried, considering that it was difficult to insert the inflow cannula into the LV due to the small size of the ventricle. Now let me show you the intraoperative video. Air-to close clamping was performed with routine bicarb cannulation. The main pulmonary artery was opened with a transverse incision at first, and then the 12 mm sized hemorrhagic graft was anastomosed by continuous suture method. And then the aorta was made a longitudinal incision on the proximal at the site of root cannulation, and the 12 mm sized hemorrhagic graft was anastomosed in the same way. Left side inflow cannula was planned to be inserted into the left atrium due to the small size of the left ventricle. For atrial cannulation, the right atrium was opened, the atrial septal wall was excised according to the size of graft to connect, and the 14 mm sized hemorrhagic graft was anastomosed by continuous suture. After adjusting the length and direction of the LA cannula, and it was tunneled and pulled out through the skin. After that, the LA cannula was connected to the hemorrhagic graft, which was anastomosed previously to the septum. Stent sutures were given in each of the 4 directions, and reinforced sutures were given in several additional places and fixed by tying twice between the cannula and the graft using black silk to secure them once more. The right atrium was closed except for the connected LA cannula and graft. Before right side inflow cannulation, the cannula was also tunneled out through the skin with adjusting the length and aligning the direction. A new incision was made in the lateral wall of the right atrium, and the RA cannula was directly anastomosed to atrial wall by stent sutures in 4 directions and multiple reinforced sutures. After the PA and aorta cannula were also pulled out through the skin respectively, the PA cannula was connected to the previously anastomosed hemorrhagic graft by continuous suture method, and the aorta cannula was also connected to the previously anastomosed hemorrhagic graft by continuous suture method by matching the length. This showed the final view of the cannula with the connection and tunneling out of the skin from the patient's right. The cannula connected to LA, aorta, RA, and PA emerged. After that, connect the VAD pump to the end of the cannula according to the inflow and outflow. Finally, the LVAD and RVAD pump were connected to cannula, and LVAD and RVAD were started while weaning the cardiopulmonary bypass slowly. After surgery, the chest X-ray showed that the heart was smaller than before. There was no thrombus in the hemorrhagic graft connected to the LA cannula coming out through the septum in the CT following up postoperatively, and the lumen of the graft was intact. It also can be seen that each cannula is well located in the 3D reconstruction image. She was transferred to the ward in a stable state. After that, she was able to receive a heart transplant 28 days after body implantation. Thank you for your attention.